It is moderated by the wonderful Keith Hauptman, the Chief of the Civil and Community Rights Unit. Welcome back, Keith.
Thank you so much, Ari. And you'll see on the agenda that this was supposed to be moderated by my amazing colleague Kate Sabatini, who unfortunately could not make it today. She had a last-minute work conflict, so you're stuck with me. But I'll do my best to pinch hit today. I have a great panel backing me up, so it shouldn't be that hard. I'll briefly introduce them. We'll get started. First up is Dr. Hauptman, who was introduced before, and we're so fortunate to have back in Rhode Island for this event today. Next to Dr. Hauptman is Dr. Jeanne Ziter. Dr. Ziter is a pediatrician practicing at Thundermist Health Center in Woonsocket. She's a member of the Woonsocket Lead Coalition, which collaborates with community partners in the Childhood Lead Action Project to decrease lead exposure in children by testing kids and fixing houses. At the end of the table, we have Vin Green. Vin represents victims of toxic lead exposure, including lead, at the law firm Motley, where he is a partner. And our final panelist next to Vin is Jim Vincent. Jim is a civil rights activist and community advocate who served for many years as president of the NAACP Providence Branch. He's currently a senior advisor at the Black Lives Matter Political Action Committee. And both Vin and Jim are advocates for the rights of communities impacted by lead poisoning and have played a critical role in enacting new laws to prevent childhood lead exposure while expanding victim access to support services. So thank you to all of our panelists for being here today. Yeah, we can give a round of applause for that. Easy crowd, right? I thought that we've learned so much today. I've learned so much, and I feel I'm pretty close to the work. So I'm really excited to have learned from Dr. Hauptman about some of the research supporting the work that we do, from all of the program managers at the different lead programs, kind of understanding how states can respond, how we can do a better job. But I want to bring it home to the kind of individual level, to the people who are really poisoned, to the families who are affected, to really your work, to all of your work, both treating, representing, and advocating for communities. And so I thought maybe just starting with Dr. Hauptman, if you could all just tell the story of lead poisoning and what it really means to you individually.
Thanks. So I think you heard a lot about sort of my lived experience and trajectory. I think what keeps me inspired is seeing the families and helping them through. I think it's incredibly, I think as a parent, one of the worst things someone can tell you that your child has been lead poisoned. And I try when I talk to families not to use that word as much as I can. And to really sort of, because I think that word could be stigmatizing, I think, for good, and the gravity behind it to get policies in place to protect our children, etc. But I think as a parent, that word can be really paralyzing and minimizes all the other amazing things you do as parents and caregivers to try to take care of this little human. And so I think for me, that sort of keeps me going to keep wanting to do this work. And also I think there's so much public health success, there's so much still to do, but so much public health success in the work we've done in lead poisoning, and how do we effectively protect our children from all environmental chemical exposures. I think in the US especially, we have this assumption that, it's in our, the food on the supermarket shelf must be safe, for the toy I buy must be safe, for the house I buy must be safe. And I think recognizing that we still have a ways to go in environmental regulations to protect especially our most vulnerable and overexposed communities. So that answers the question. But
So certainly, my first foray into lead is, when you're a resident in a hospital in a large city, and for me that was several decades ago, and that was back when we thought that leads under 10 were fine, and so. You have that exposure to the kids with high lead, but we're thinking that, most of the other kids are doing okay. And then, moving to Rhode Island, that was in Philadelphia. Initially, I was in private practice, and while we tested kids, I really didn't have too many cases. Not that it can't happen, in families that are out in the suburbs, as has been discussed. But then my last 8 years, I've been at a community health center in Woonsocket, in one of the core cities here in Rhode Island, with a very high, up to 80% of old housing stock, and a high rate of folks of color and low income who don't own their own houses and who don't have the opportunity to have a lot of choice about what houses they can be in because they can't afford them. And so this is when I started seeing more kids with elevated leads. And as we know more, now again, worrying about any lead level makes me worry about every child that I see. And so, our first task is to test kids and to try to let parents know why it's so important to do that testing. And then now even my stomach drops when I see a 2, because I know that there's lead in their environment somewhere, and yet it's not high enough to get services yet. And so working with families, having to tell them that their child has had an elevated lead, and then trying to explore with them the reasons, perhaps why, what the housing is like, and then what are their options, and do they have somewhere else they can go? Do they feel comfortable talking to their landlord? And I thought initially when I learned about it that yes, I could identify it, I could bring them the information. We have resources here in Rhode Island. People will reach out to them and come and inspect the house and teach them and give them supplies for how to clean things, and we can try to get someone in to inspect. And I thought, great, this is gonna work, this will work. I have things I can do. And yet what's been interesting to me is the barriers that I'm running into in terms of getting some families to agree to those services and to be willing to talk to their landlords, and to be willing to try to find the services for their children, especially when the best thing maybe would be to move out, right? To move out quickly, drop your child's lead exposure, move out to somewhere else, and they don't have anywhere else to go. They don't have any affordable housing that they can access. And so these are big struggles that keep me up at night and keep me going.
Vin? Oh, sorry, Jim. Let's go with Jim first.
Jim or Ben? Okay. Well, good morning. For me, I came to Rhode Island in 1990 to become the housing coordinator for the city of East Providence. And early on, we were made aware of the problems with lead poisoning in children. And I think we're probably the first city or municipality that really actively have programs, to help mitigate lead poisoning in children. I know Brenda Clements here, she was at the Housing Network at that time, early 90s. But I know that our planning department, and I worked in planning, worked closely with whatever community groups were there at the time. I think Childhood Lead Action was formed then, early 90s, I'm not quite sure when it was formed. But we worked with Rhode Island Housing, and I knew it was an important issue in terms of communities of color. It's a civil rights issue as far as I'm concerned. You talk about black maternal health, you talk about sickle cell, you talk about prostate cancer. This is an issue that is up there with those issues in terms of communities of color. And I remember testifying, on behalf of the Attorney General's office, and we got those bills passed, thank God. And one statistic struck me in my testimony, and it was in 2019, kindergartners of color made up over 60% of all students with elevated lead levels, 5 micrograms per deciliter. Urban core communities where the housing stock is overwhelmingly pre-1978 have the highest lead poison rates in the state. In Providence, 1 in every 5 elementary school students has been lead poisoned. 1 out of every 5. 60%. I mean, these are huge numbers. So for me, and I have been a civil rights activist here for 30 years, 9 years with the Urban League, and the last 20 with the NAACP. it's something that I've always been concerned about, and something I've always responded to when I've been asked to do any work within that space. So I'm here to help in terms of how to get further down in terms of the targeting of communities, because Rhode Island is one of the most diverse states in the country in terms of communities of color. And it takes some knowledge in terms of those communities to really be effective, I think, in terms of getting the word out.
Ben?
So it's appropriate I'm at the end of the table here because I say sometimes that I'm the person of last resort. Nobody shows up in my office because they just want to come visit with me. They're always there because something terrible has happened and they don't want to be there. And in the context of lead, I've represented children and families for lead poisoning since literally I got out of law school. And we are still prosecuting cases in Rhode Island involving landlords today. In many cases, unfortunately, we're prosecuting cases where we've seen those properties before, maybe in one other case or two other cases. You would think that that would be discouraging. I mean, I'm here to give you some good news and the obvious bad news. The good news is, we don't see the kind of levels we used to see. When I started, we were prosecuting cases where blood levels were extremely high, 2 digits, 60, 70 micrograms per deciliter, 80. We've had cases where the blood levels were even over 100. In one case where the girl had a blood level of 108. My partner Bob had a case where the blood level was 185. The good news is we don't see those cases anymore. The bad news is, as we said earlier, while we've been doing this work all these many years, the science has changed, and we've learned that even the levels that when I started we thought were safe are not safe. So our cases have changed, and we're still seeing kids who have blood levels of 15, 20, 25, occasionally 40. To give you some sense of what a case looks like, when a family comes in to see us, usually the children are about 2 years old. We need people when that exact moment where a child's moving around their environment, they're exposed, there's the hand-to-mouth activity, and a blood test reveals lead. But we're then years away from that case ever actually being resolved, because there's a gap between the blood level being discovered at the age of 2 and when we can really prove the case, which starts at least about age 7. We can't have a child properly evaluated via neuropsych examination, or it won't be valid anyway, scientifically valid, until about the age of 7. And so we spend a lot of time with these families. Our cases go for years because that's the nature of the science. And we'll say, in all the things that I do in my practice, the days we resolve a lead poisoning case are frankly the best days, and here's why. What y'all may not know is when a case like that resolves for a minor, we have to have it reviewed by the court. There's a procedure where we have to have what's known as a guardian ad litem setup. So we have an independent lawyer who looks at the case. They have to evaluate the settlement. They have to decide, I did a good job, the parent's doing the right thing, and the settlement's appropriate. And then the court actually expects us to put any settlement proceeds in some kind of trust for the child. And so, why do I say these are good days? It's one of the rare cases in litigation where we're doing something prospective. And so for every child we've resolved a case for over the years, and it's been in the hundreds at this point, every one of those children has something set aside for them for the future. And the last point I would just make is, why? What does that look like? We all know lead poisoning is a permanent injury, but from our perspective, when you litigate a case like this, part of the evidence in that case is lifetime loss of earnings, lifetime disadvantage, vocational training. There's a whole series of assistance and services that may be required. When we have a trial in one of those cases, one of our experts is an economist who they generally opine that a child who's been lead poisoned has lost hundreds of thousands, if not in the 7 digits, over the course of their earning life capacity alone. That's just the economic loss, not to say all the other aspects. So these are good dates when we can resolve a case like that, even though, unfortunately, we're still litigating.
Thank you all so much, and there's so much to kind of go on there with all of your diverse experiences on this issue. But I want to drill down on the outreach issue that I think all of you kind of touched on in different ways. And I first want to make sure that I'm kind of understanding something that Dr. Hauptman said. I think you were kind of saying that you don't like using the term lead poisoning with families. Is that right? You use elevated blood level. And this is something that I like, a divide that I've noticed between maybe lawyers and physicians. I mean, I say lead poisoning, you say elevated blood load level, and to me that sounds like, kind of euphemistic, and yet I understand that we don't want to stigmatize children. I understand that we want them and their families to know that this is not something that will necessarily dictate their path in life, but that, epidemiologically, it's like it could have an impact when we look at population-wide data sets. So how should we do outreach to families to encourage them to get tested when the testing is available, to, as Dr. Ziter pointed out, comply with requests to allow remediation to happen. But at the same time, I do want to zoom out for a minute and say, we see that in our practice sometimes, that the non-compliance issue with families, but I think far more often we do see non-compliance not involving the families, right? Involving property owners. So anyway, how can we do a better job with outreach, and how should we talk about this issue? Yeah, Jim you've got a wealth of experience
I
on
can short
community outreach.
straw. Well, I think we have to look at what we have here in the state. I mean, for example, talking about poverty, poor people, poor kids in general. In Rhode Island, there are community action programs that have qualified health centers, okay? Believe it or not, there are only 10 community action programs in the country that have qualified health centers attached to them. 3 of them are in Rhode Island. And one of them, I'm the chair of the board, East Bay Community Action Program, that takes in 10 communities. And I look at this chart here in terms of elevated lead levels, and number 2 is Warren, and I think number 6 is Little Compton, number 7 is Bristol. All those communities are in our catchment area. So if we can reach out, I think, more to the community action programs as well as the community health centers, that is something that we could do more of, I think. I'm not quite sure the levels of outreach we're doing, but we can do that. There are churches and mosques that would be glad to do things with anybody, okay? I used to promote first-time homebuyer programs when I worked at Rhode Island Housing. We have to utilize people that are gatherers of people and in the appropriate languages. I mean, in Rhode Island, we have a very big, diverse community of color. We have over 25 countries in terms of Spanish-speaking. In the Caribbean, South America, Central America, we have 55 African countries, like 40 of them represented here in Rhode Island today, speaking different languages or whatever. So, I mean, there is a way of drilling down deeper, I think, and being more effective in terms of reaching people, if we just break it down a little bit more. We have also an African American community that is not just in Providence. There's a large community in Woonsocket and in Newport, and as well as East Providence, Pawtucket, and Central Falls. So I think what we need to do is talk to people that are good at outreach and know the communities well, and know the different languages, know the difference between Haitian Creole and Cape Verdean Creole, for example, and move there. Because I'm telling you, it's a very complicated situation in terms of the diversity here, and unless you know people that understand these different communities, you're going to be missing the boat in terms of missing large swaths of people that you don't want to miss, because they're the people being disproportionately affected. So to me, it's just making sure that you know the people that know the people that are on the ground doing the work. I mean, for example, how many people know there's an Andean Association, the Andes, okay? How many people know there's a Pan-African Association in Woonsocket? I mean, these are things that, these are groups that are more than willing to help because they see it as an issue in their communities, because it affects all children, especially in those inner cities. So I'm going to stop there, but it certainly, we can do a better job in terms of targeting.
Yeah, and Jim, just to clarify, I mean, your opinion basically is if we're talking to people, sometimes literally speaking their language, but really, meeting people where they are, giving them the information, in your view, people will kind of come to the conclusion that, these laws make sense, we should be looking at the issue?
Yeah, it's like anything else. The better the information in terms of how it's delivered and in terms of what form it is, the more effective, of course, it's going to be. And that's true about anything. So I think we just need to make sure that we understand the populations, deeper in terms of who's being affected. I mean, okay, black people, Haitian people, Nigerian people, Cape Verdean people. I mean, we have to understand that, you know, the diversity there is huge in that the languages are different, and they're as different as Italian and German. I mean, very different. So we need to be able to have people that can speak the language or surrogates, and we have to be able to, within budgets, translate information that it goes out. But if we don't do that, we're not going to be effective. Not in a state like Rhode Island. Here's a stat I think that most people don't realize. We talk about the black community. There's probably more non-African American black people in Rhode Island than any state in the country. Okay, so we'll just leave that there. So that just shows you where the challenges are.
So, you know, I think there's two different ways to look at this. One of them is we are so far out now from, you know, the banning of lead and interior paint, and then even the 1991 federal law and the 1991 state law, that there really is this general community idea that this isn't a problem anymore. So first of all, there's a kind of a global education that needs to happen. And that's particularly true, I think, for renters. You know, there isn't anybody who buys a piece of property in Rhode Island doesn't have some inkling that this is an issue, because you have to check off that box about pre-1978 property. Renters don't know that this is still an issue. Renters don't know that this is still a pervasive problem. I would say that virtually every client I sit down with, they are shocked to learn that this is a problem. This all comes as a shock to them. And then the second layer of that is how pervasive it is. I still run into people, whether they're defendants or sometimes even clients, who are under the misconception that, or somebody says to me at a cocktail party, well, isn't lead just kids chewing on a windowsill? No, for the 1000th time, no. And so, you know, it really needs to be some education and outreach on just how insidious, I love that phrase, fugitive dust, and just how dangerous this is. And then I think the last part is that disclosure to tenants, building off of that. You know, most of the time, the first thing I ask a client is, when you rented this property, did you receive the pamphlet that you were supposed to receive? Most of the time they don't. And sometimes the only, this isn't a criticism, but sometimes the only penalty for that is me. Meaning that's the first thing that goes in my complaint. That's your first law that you violated. Let's talk about what the next one is. And so a lot of this really is, you know, to some degree, enforcement on the property owner side and education on the rental side, that this is still an issue and how insidious this issue is.
Yeah, that's such a great point that, you know, the non-compliance with property owners, a lot of it does have to do with the education, right? Because for those that don't know, the basic framework is the property owner is supposed to provide all sorts of disclosures about the presence of lead, about your rights as a tenant with regard to lead, about, you know, lead-safe work practices when abatement is happening. And so if that isn't happening, then there isn't really a framework for tenants to find out about this as an issue. Dr. Ziter?
So I think that I would say most of my patients don't know enough about lead, or when they are going to rent, I don't know that they know the right questions to ask, or that they have that many options. You know, sometimes they're choosing between a property that has mold and a property that might have lead. And so I do agree that I don't think as a society that we talk about lead enough and that people really understand it. Not everybody knows someone who's been poisoned with lead. And so it definitely comes back to the whole community to continue to raise the issue. You know, certainly for us in the medical field, yes, you know, we have mandates to test. We need to keep talking about why. Nobody wants to take their child to go have blood work done, right? That's no fun, especially if they just had a bunch of shots. But really explaining why it's so important. You know, this is critical for, I tell parents, I know that it's hard to take them, but I really need to know, and you really need to know, that these levels are okay for their development, for their brain development. You know, trying to put it into a perspective of what is this lead thing and why does it matter? You know, this issue of lead poisoning versus elevated lead. I agree with Dr. Hauptman that it's trickier. It's tricky when you talk to families, because I'm not trying to put them in despair. They immediately think it's their fault, or it's something they did or something they didn't do, and I need them to engage, and I want them to have hope. I want them to engage with me so that we're a team, but also that they understand that, you know, that we have a larger team, you know, that we're gonna be working with the people that own your housing and the Department of Health. And then as soon as I say Department of Health or something with the government, I do get a lot of pushback. Oh, in our community, when these things came up, then someone was calling DCIF on my family because I very much appreciate what Jim said, which is that we really need to get into communities. And because we do know where there's a lot of buildings with lead that are old, those of us who work in the communities in particular, I think really need to work together to work on committees where we involve people from the community so that we can understand what the community feels about this, what they know, what are the barriers, what misconceptions do they have, what can we do to help the community as a whole spread the word, how can we get out to different community activities, whether it's, like you said, through parishes, pastors. We try to do outreach not only at the clinic level, but we go to, try to do things for educators, daycares, and we try to do testing and education at the WIC programs that most of our patients who are under 5 avail themselves of, for nutritional support. We need to keep finding clever ways to get the word out into communities, but something more targeted in their catchment area and directed toward the issues that they're concerned about. And then they can be part of the process in helping us how to reach people better and then how to work with people in a way that they'll be trusting and that we can make a difference.
So I think what I'm hearing in part is like the message kind of depends on the context. Like the way that you might talk at a community meeting might be different than you talk to a family that's been affected by poisoning.
Yes, there's the general education about lead and where is it and what are the long-term effects and how can you find out if your property is affected, how can you find out if your child is affected. The prevention, the primary prevention, which is what we really need, is to fix houses, right? Fix houses before kids are exposed, but then there's a different conversation once your child has elevated lead and we know that your property that you're living in is most likely has lead in or whatever else sources.
Yeah, I think that's really well said, and I think I would agree. I mean, I think certainly the context and the nuances matter. I think I sort of hear myself saying the same thing a lot with families, is that I speak to the injustice that occurred to them and like the failure of our regulations sometimes, and to try to empower them to act and to comply with the lead laws and to also engage to continue to partner with the education system to make sure that they have early intervention and to think about if there was an injustice and setting them up with legal support and medical legal partnerships, etc. But I think it's sort of that balance of also by the time they get to me, I'm a primary care pediatrician as well, but by and large, the majority of lead patients with lead exposure I see are after many people told them your child, and they've gone on Google and they've read all these terrible things, that I try to dial it back a little bit to sort of to show that all is not lost, and not to sort of reduce this one child to a number, but really sort of think about all the other things that we can do to support. And I think it also changes like the duration, like a first time lead level 4, I say this is great, this is exactly, I don't say this is great, but I say this is why we test, this is why you have a great pediatrician and you went and you took your child to get their lab tested, and that was really great of you, and I know that's hard, and you identified that your 9-month-old has a 4 and it's not higher, and you now see your home and see all this big pain, or don't see it but still have a 4 and have to sort of figure out where it's coming from. And so, but I agree, I think the misinformation around even pediatrician colleagues that I've trained with at the best hospitals in the nation say like, well, why can't parents just like not let them eat chipping pain? I say the amount that it costs to cause even a TED is so microscopic, and it's just lead, lead, and dust that, I also sort of run the line of like freaking all of my colleagues out. But, so anyway, so that balance I think is super important to tell each and every parent that this isn't your fault. And even if the landlord tells you it's your fault, this isn't your fault. And even if you feel like it's your fault, this isn't your fault. And hopefully that message sticks.
And I love that kind of like flipping the low level levels on its head a little bit. I mean, it is kind of an opportunity, right? I mean, it is that we heard the research about how low lead levels can have really significant effects on IQ and other cognitive deficits. But it's also like a wake-up call for a lot of people. We hear that a lot, and frankly, I've heard that outside of work quite a bit, where parents have, their kids have a low lead level. And it's like, I had never heard of this issue. I now am going to like really look at it. It's a 2. That means that like technically I'm not entitled to any like state support, but there's obviously code enforcement. We can work on getting the home into compliance. So I want to touch on the injustice issue, and the fact that the family is not responsible, which I think everyone agrees with, and so like where this injustice started, and I think that the history here is really kind of an interesting and really relevant point in this conversation. Maybe starting with Vin, what is the history of lead that's led us to this point of injustice?
So, like any classic corporate bad actor story, we could talk about tobacco, we could talk about asbestos, we could talk about opioids. Lead is the same story in a different package. This package happens to just be a pint can of paint. The companies that made these products, particularly in the pigment industry, knew for a very long time that they were dangerous, lobbied against regulation, and to be very candid, very clear, the things that they wrote down were horrific, genuinely horrific, writing about minorities and what they referred to ghettos and who really cares if these kids are dying, and I'm gently paraphrasing, they're much worse than that. And so there's a decades long, and again, this isn't my perspective on it. These are documents, these are hard copy documents that we got in litigation. My firm, in addition to working for individual kids, we represented the state of Rhode Island against the lead pigment industry. We tried that case, and now's the moment where I have to say, if the Supreme Court had done something different, we would be having a very different conversation today. But it is a story of classism, it is a story of racism, it is a story of profit over people, which is in large part, and most part, why we have a legacy lead paint problem in this country today. Like many other corporations, like the ones I've mentioned, they knew while they were selling these products that they were dangerous, and they said, damn the torpedoes, no one's gonna care about these kids, just keep selling it and keep using it.
And you mentioned that they knew, I was talking to somebody who is from Greece, and they mentioned that lead is not an issue in Greece. Could you shed some light on why that is?
Well, because they didn't have the lobby, they outlawed it, and they outlawed it early, and it wasn't used. And here there was a decades-long effort to continue to use paint use lead pigment in interior paint.
Yeah, it's such an unbelievable dynamic where, so I think it's throughout Europe, is that right?
Yeah. It was
outlawed
banned long before it was banned in the United States.
Right. 1978 banned in the United States, 1908 banned in Europe. So the lead paint companies knew about this issue for decades, that it continued, and I'm like getting a shiver down my spine thinking about it, and just continued putting it in the housing stock.
I mean, that's 70 years of continuing to coat the interior of the homes, the housing stock, particularly in the oldest cities, with what they knew was a neurotoxin. And again, I don't want to belabor the point, but they knew kids would die, and they wrote about it, and they wrote about it in the most offensive terms, and just said, well, we can continue to lobby, we can continue to prevent regulation, we can continue to prevent this from being outlawed, and we can continue to make money. I like to bring the room up.
Jim, any
Well, he said it all. I mean, it's not the first time certain communities have been targeted with things. And so I don't think anybody's surprised by it. The whole thing is that now we're left with the result of it. And with the school children not achieving what they should be achieving, and then leading to people not being able to get gainfully employed, leading to people being incarcerated. So, I mean, it's a societal issue on an enormous level. So I can only say that, it's an urgent issue, and that we need to do better in terms of getting the message out to the people, especially those being affected, in the ways that they can receive the information best, so that we can be more effective. And I know I'm willing to help out to anybody that's serious about getting the word out in terms of a targeted fashion, because it's just that important as a civil rights issue. So it's no surprise there that communities of color were targeted, in this country. I don't think anybody's shocked by that. But the fact is, now what do we do? Other than shake our heads, we'll move forward so that we can effectively help communities and people, one child at a time, if need be.
I think that that's the crux of it, which is that we need to continue the big work that comes right even from the funding that states get from the federal government to be identifying and fixing houses, and right down to our state level, right down to our community level. I really got involved in this issue probably about 6 or 7 years ago when I was asked to be part of the Woonsocket Lead Coalition, and it was I'm going to do shout out to the Children's Lead Action Project and Laura Bryan, which is a grassroots organization that's been working on this for a long time. And they are integral into helping communities, individuals as well, but helping communities at all levels to try to work on this in their own community and come up with their own community solutions and supporting them. And so it started with a astute nurse at the Head Start in Woonsocket wanting to bring together stakeholders, and so people like myself representing the the community health center, and people from WIC, and people from the Lead Action Project, and people who work at the mental health center, and people from housing, and different people who are all interested in young children, right, and prevention, and trying to get right on children who have exposure to lead, and let's get them into educational supports that we know will help mitigate this exposure and improve success. And from there we would just meet regularly and come up with ideas, what are we seeing, and starting with working on screening, how can we all work on screening, while we would love to fix all the houses so we don't even have to screen because nobody will be lead elevated, that we've got to continue to look for it until it's all fixed. And so how can we do that? We as a group have done outreach in different areas in Woonsocket. And we as medical providers, are working this into our quality improvement projects, right? And so, we have all these electronic health records and all these databases now, right, that we were required to have from the federal government, right? So we might as well put them to some good use. And how can we look into our data, and how many kids are we screening at the appropriate times? Are kids getting their screens around a year? Are they getting another lead screening, another blood test when they're around 2? If they're not, how do we reach out to them? We run reports. We should see, who are we missing? Let's go back out and try to reach out to them. If we can't get them by phone, we will send them letters. If we know they're in Head Start and they have outreach, we have a partnership with them, and we can say, hey, can you reach out to this family? We've been trying to get a hold of them. Their child needs to be screened. Or then the children have been screened and the lead is elevated and we're still having a hard time reaching them. Again, using our community partners. And then once we figure that out, what do we do about it, right? What do we do about it? How do we get them the support they need? How do we help them advocate for themselves? And how do we stick with it until things are fixed? And then how do we use our registries, right? I'm delighted to hear about these registries coming in with, with backing behind the law so that people can learn about where can they go and then how can we help them afford to get there. And how can we get the housing to be safe? We want new affordable housing that is safe, and then we gotta fix all the old housing. And not fix it every 5 or 10 years, but can we fix it permanently? Can we get rid of the lead so that we don't have these repeat offenses? Not, having a child come in and then 10 years later, another child is coming in to the same property. That's a crime. That's everyone needs to grow up in healthy housing. If we really want to make if we really want to change the outcome of kids and families' lives, we need to start early and we need to fix it, and it has to be an emergency, and it has to continue to be an emergency.
Sometimes it can literally be a crime, by the way, and that's an important piece, as we talked about earlier, that stick that nobody wants to exercise, but probably does have to be there. I think there's a lot to unpack there, and I want to try to. But you were just talking about a lot of the interventions that happen when a kid is essentially in the system, right? Like they've been screened, elevated blood level, everybody now working, the system kind of working as it should, which is great. And the AG's office is part of that system, along with a lot of other partners that are really in this room. But it doesn't always work that way, obviously. There's some charts out in the hallway about the screening rates in Rhode Island. We're pretty good. What are our screening rates are like? I think we're at 72% full compliance or something. And then maybe 90% of kids have been screened at least once before the age of 3. So, okay, so something like that. So it's so full compliance would be tested twice. And I see Michelle up there, she probably knows. But 53? For full compliance, okay, yeah. And then I think for at least partial compliance, close, is that it? Okay, so two-thirds of kids? Okay, so maybe a third of kids are not being tested at all. So we know that the problem is way bigger than the statistic of the number of lead poisoned kids each year. So one of the things that you've been talking about, Dr. Hauptman, is we should think about lead in the context of other environmental exposures. But I want to think about lead in the context of primary health care more generally. I mean, these kids who are not getting screened, how are we failing them? And by we, I mean of course the society, but maybe our healthcare systems in particular.
I was going to say one other thing about injustice, so I'll pause that. But no, I think it's heroic work that it takes to sort of launch these quality improvement initiatives and partner with multidisciplinary partners, because most of the time this is sort of unfunded, non-billable. I think I bill for this much of the work that I do because one, it's just too cumbersome to bill for all of it, but and so it's really sort of the blood, sweat, and tears of all of the Department of Public Health partners that are mining the lead registry that and when a high level comes in, they know exactly how to respond to it, sometimes very much off business hours. And then how do we outreach and sort of think about a population management approach and leverage the data? I think I was a math major in college, so I'm a big data person, and I really think it's sort of both bringing the data into the medical system so the clinicians can also be the advocate and say, oh, it looks like you live in a home that hasn't been inspected yet. Maybe we should connect you to DPH or Department of Health to act on that, and sort of like Terry Howard was saying, sort of integrating lead poisoning prevention into different sectors that they may not be. One last thing about injustice. So one population that I didn't talk a lot about in my presentation that is close to my heart is sort of cultural and alternative source of exposure, and I think that's also a really nuanced conversations to be had with those families, and I think it's an injustice, and I always sort of frame it as, in the US we have problems with lead being put in our paint supplies for far too long, or our soil, or these kinds of things, and in other parts of the world there's lead in other things, and I think it's heartbreaking sometimes, and it requires a lot of cultural understanding, and I think partnering with the appropriate community agencies to really also share with the families that, like, because I think a lot of times the products that the lead finds its way to are very culturally tied, right? It's the jewelry that they brought over from India, where my husband's family from, for example, or South Asia cultures, or it's the imported cookware that they cook their really perfect meal in, and now we're telling them that is causing their child to be poisoned, or it's the religious cultural powers. And I think those conversations are really nuanced, and I think it happens a lot with lead inspectors and others when they, live in a 2000 home, and they're like, oh, it's because all these products are foreign. And I think I would just urge you to be mindful of sort of your cultural sensitivity, I guess is the word, and how that would feel if someone sort of told you all the products that you grew up with are making your child sick. So it's just my little soapbox. And I always like saying, my husband grew up in India, so I totally get it. And but so that helps me. But those products and those sources are a lot of times really meaningful for recent immigrants.
So, and I think that is so important for those in the room that are like looking to drill down the consumer products issue. I know that New York City has done some amazing work in that area, and unfortunately they couldn't be here today, but you could certainly follow up with them. Actually, related to New York though, on that first question, and maybe bringing Dr. Ziter's perspective into it, I'll admit, I'll just blame myself on this one. I had this idea, and I was like, oh, like all the kids who are screened or aren't screened are tied to a pediatrician, because like everybody has to have a primary healthcare provider. And so we could just like send out a report card to all the pediatricians and say, like, you did a bad job. Only half of your patients have been screened. And apparently like something like this, can be done and maybe has been done in certain ways before. But New York City, when I talked to them, they were like, oh, well, you have to be careful, because it's not really fair to blame the providers, right? Like, it's really tough. Like, sometimes a kid is like randomly assigned to a provider. There are kids who we don't even know about being in the system, right? If they move to a state like after they're born, but before they go to kindergarten, like they might not have a healthcare provider at all. So anyway, like, how can we in Rhode Island, like, how can we, in a fair way, encourage providers to screen? And, to the extent that there are failures in the primary care system, like, that make that harder, like, how can we fix them?
So that's a big question. Okay. I'm going to start with education, right? So I think we need to continue to talk about lead and other environmental hazards in homes in medical education. We're not seeing as many kids with those high enough lead levels to get to need hospitalization. And so we need to continue to talk about the lower levels of lead and how to screen for them, the importance of it, both in residency training, and then I think we just need to keep talking about it in state medical conferences. It needs to keep coming out in the journals that physicians and nurse practitioners and PAs read.
So you think it's fair to put a little bit more pressure on the providers?
Well, I think so. I don't like blame. I like education, right?
Of course.
Okay. And so, so why maybe are kids not getting screened who have a primary care provider? Okay. One could be lack of education of the provider. Okay, that's possible. That should not happen, right? That should not happen. Two would be providers who live in communities where they don't see much lead, and so they get either they just don't, there's so many things that we have to screen for and that we have to ask about and that we have to look for in very short visits and things like that. So that sometimes people are ranking what they're going to do, right? We need to do them all. We should be doing them all. They're all important. But if something falls, if you don't see it very often, if you don't see an elevated lead very often, you may be less likely to push, right? To make those extra calls, to get those patients in. So we need to keep that message out there, right? We need to keep that message out there. And then there's access to having the blood work done, right? So there's different ways that you can test. And so do you go to your doctor's office and they have a system in place where they, do good cleaning of your finger and draw a blood sample from your finger. It's called a capillary. And that is very easy for the families, right? If you do it right there in the office, they don't even leave the exam room. It's like getting your vaccines, right? Most of us don't do the visit and then say, okay, now you need to go down this hall and take a number and wait in line to get your vaccines, right? That would never work, right? Half the people would walk out. And yet that, for many of us, that's how it works, is that, okay, here's the order, right? This is why it's important. I might even, if I'm good, attach the handout from the Department of Health that explains the importance of it and why we need to do this and what are the consequences of lead and what you would do with an elevated lead, right? So, so if I take that little extra time to explain why, but I don't do it right there in my office, right, before they leave. And yet I'm good. I can have a community health center where I have a lab downstairs, right? All they have to do is walk downstairs, but still they have to get in line. And what if the line is long, right? And their child's antsy and they're crying, right? So trying to make that as easy as possible for families, so it's easy access. Well, that's not always available to, say, private pediatricians out in the community who have a small practice, right? They may not have a phlebotomist right in their office or a lab right in their building. It might be down the road. So every time you make one more step that makes it a little bit further from right now, you run the risk of it not getting done.
And so just for those that don't kind of know the system, I've been through this with my kids, so I kind of have learned, including at one of the DOH lead screening events, where my son was very unhappy to learn that he would be getting a venous draw. I told him it was a finger stick. But so there are pediatricians who advocate for not doing the finger sticks at the get-go, because if you get the positive finger stick, then you still have to do the venous draw to double check and to make sure it's accurate. And so it's like, why not, especially in communities with higher levels of lead poisoning, why do the finger stick when so many kids have the elevated levels that the families are gonna have to go to Quest or whatever, and it's a big pain, and you get your kid to do the venous. So just do the venous off the bat. Do you kind of advocate for that in Woonsocket?
So we right now, because we have a lab right in our building, we do the venous, right? And the other issue about that is that I'm drawing lead, but I'm also looking at hemoglobin, right? So that's another measure that I have to measure is, how their iron status is doing. And so, for me, to do one stick and get both samples, and I can get a CBC, which is an extended panel, so it gives me even more information if that hemoglobin is low. That, just from the number standpoint, that's better. It's more accurate, it gives me more information, and I don't have to bring them back and do those confirmatory tests, right? So, and one of our sites, we've been trialing with the Department of Health doing some capillaries because we found that the lead level testing was low, and that takes some work itself, right? It's not difficult, but you have to be trained properly and you have to have space. You have to have space because if I leave that child in the room and expect a phlebotomist to come in, now I'm holding up patient care, right? I only have a certain number of rooms. So there's a lot of logistical things that get in the way. I think what we need to do is both, right? Whatever your practice needs, whatever your practice can accommodate that makes it the easiest for the families, looking at, will your patients go? What helps them go? Is it hard to get a hold of them afterward, right? If it's hard for me to get a hold of someone afterward, then I need to do everything I can to try to get them to get that test done that day.
So that totally makes sense to me. When you have little kids, obviously parents are just totally stressed out all the time, and anything that makes it easier probably increases compliance rates. Starting with Vin and then maybe working down the line as we wrap up, so far today we've we've learned a lot, and maybe you all learned about the different state approaches to regulation enforcement. You know, we've talked a lot about families, we've talked a lot about outreach, we've talked a lot about the history of lead poisoning. You know, what's something that government could do better to increase outreach, to increase screening rates, to respond better when a poisoning happens, whatever you think we could do? Just if you've got an idea or ideas, that we'd love to hear them, I think, going.
Sure, well, let me just say first, I want to give a shout out to the Department of Health. I've represented kids in about a half a dozen states, and I've looked at hundreds and hundreds and hundreds of lead inspection reports, and by far the ones on Rhode Island are far and above anything that you see in any other state. And just the level of detail, how conscientious they are, how thorough they are, the follow up on the notices of violations. I love it when you said multiple notices of violation. It makes my job so much easier. Just following up on the screening thing, we absolutely should be targeting 100% success rate in screening. But what I would add to that is that conversation has to happen in conjunction with lead-free homes. Now, don't throw things at me. I know how difficult that is from a financial point of view, political point of view, regulatory point of view. But the reality is, and this is essentially what was litigated in the lead industry case. The presence of lead is, despite what the Supreme Court says, is a public nuisance. It is. Every house that has lead in it is a potential hazard. It is ultimately an inevitable hazard because that paint will always degrade and requires constant vigilance and maintenance, which I just frankly think is unreasonable, particularly across the housing stock. And so I'm being pie in the sky. I'm not going to give you a way to get this through the General Assembly or something like that. But from my perspective, where I sit, kids to some degree are still canaries in the coal mine. They are, and until we are lead free, until we have a standard which is removal. And by the way, safe removal, because I will tell you that some of the worst cases I've seen, the worst poisonings I've seen, are cases where a child had maybe a 15, maybe a 20, and a property was gone in and done an illegal abatement, and then that child has an 80 microgram per deciliter below level. I've seen it. It's horrific. That footnote aside, the best standard is lead free, and if I can be pie in the sky, that's what we should be talking about.
And just to second that, I know we talked earlier today about different certificates. DOH just gave us some amazing data. You know, the DOH has the full lead safe certificate, and that is either lead free or like a much increased standard of lead safe, although obviously that term is fraught. And it doesn't need to be renewed, unlike a CLC, unlike your certificate of lead conformance. And so it's great for property owners as well. And the DOH has issued like close to 1,000 of those in the last 5 years. So like not a small number. And the number appears to be increasing. I mean, it's a small data set for the last 5 years. But you know, to the extent that you go out in the community and you talked about the certificate of lead conformance that has to be renewed every 2 years, and there is another option for property owners that want to fully abate. And there is an option in Rhode Island law to like get those units certified as like permanently safe for families. Vin? Jim, excuse me.
I get that a lot.
Yeah.
Jim Venn, well, four quick things that come to mind. First of all, you sing in the choir. I spend most of my career in housing, so lead-free housing definitely is something to be we want to strive towards. But also, you mentioned 1/3 of the kids under testable. What's the demographic of those kids? Who are those kids? The government can help, figure out who are those kids. And then also, maybe there might be some cultural bias in terms of providers. I mean, we see it in Black maternal health, we see it in abundance. So maybe there's some cultural bias we need to reconcile and reckon with. And maybe government can play a role there. And then finally, we just have to work with more effective communication. Maybe government funding can help in terms of the communications that has to be done in a culturally effective way. That sometimes could be budget busting, but with government support could be realistic.
Back to testing. The other thing I was talking about was in clinics, but I think what we need to continue to do is try to find families out in the community as well. And so the Department of Health has been doing initiatives where they will go out into communities and run testing fairs, right, where you're doing the capillary, or they have started doing, except that the pandemic got in the way, capillary testing at WIC centers, right? And so WIC centers are usually in communities, low-income communities, and often affiliated with community health centers, and they have their own requirements to do capillary testing already for hemoglobins, and so trying to also do leads for kids who aren't up to date. And the trick is trying to get their database and our databases to talk, right? But because the Department of Health has and KidsNet has the data there, they can access that. So trying to expand ways that we can do testing, not just in the medical community, but out in the regular community, and working with communities about what would be places that they think people would be comfortable doing that, and what kind of settings, and would that be, what kind of message do we need to get it out that people would be comfortable doing that. So all we're continuing to work together.
I have a few. I think investing and making legacy source of lead from lead-based paint hazards a real priority. I think since the Flint water crisis, there's been an increased attention and recognition of water, but I think really prioritizing our housing stock and addressing and investing in lead-based paint hazards, soil contamination, safe renovation practices. We see a fair amount of patients with like occupational take-home exposure, so really sort of teaching and educating safe lead mitigation practices and demolition practices, etc. I think investing in our education system would complement this and be synergistic. Two other things is I think being more proactive in our how we our environmental regulations, and not put the onus on public health experts or communities or community activists to sort of prove that chemicals are hazardous to our health, but rather do that research prior to these chemicals being introduced into our environments where we live, learn, and play, or our children do. And then I think holding the industry accountable and helping, doing what Motley Rice did and others, what Motley Rice did in Rhode Island and California, and continuing to try to hold industry accountable for the public nuisance.
Well, yeah, I mean, there's a long list there.
Probably have more to.
Yeah, we've all got a few decades of work ahead of us, for sure, and but I think there's so much that we can do today too. So thank you all for all of your remarks, and I think a round of applause for our panel.